and welcome to Cardiac Grand Rounds for, I think it's the 22nd of April, hard to believe. Driving in, there were cars turned around on two of the bridges I crossed, so it doesn't seem like late April, but it is. Welcome to Calgary, Dr. Saunders. So it's my great pleasure to welcome Dr. Saunders, who is visiting from a place that probably never gets iced bridges. Dr. Saunders is visiting from the University of Adelaide, where he is director of the cardiac electrophysiology department at the Royal Adelaide Hospital and a professor of medicine and cardiology. Dr. Saunders is an incredibly well-cited researcher with an interest in atrial fibrillation, specifically identifying the substrates for the development of atrial fibrillation. So welcome to Calgary, Dr. Saunders. We look forward to your talk. And
thank you. Thanks, Andrew. Well, thanks for having me here, and it's really an honor to be here in terms of what this institution has provided in the literature over the years in our field. Satish, thank you for the invitation. So I'm going to talk about a new topic of building a pillar of AF management. Now I should, hopefully I can go down there. So I just go through my disclosures. I do have lots of industry relationships. I'll also say that I was on the writing committee of each of the guidelines that have come, and I'm going to show some of the guideline data here. And I also am an editor for European Heart. And so there may be some bias associated with that and showing some of the papers from that journal. So we've got AF burden as such. We've been focused on countries where we have data from. And we think we have a huge burden ahead of us for this. What we try to do here is look at the two populous areas, India and China, and we've managed to extract data to try and say how much AF exists there. And already there is estimated 80 million people with atrial fibrillation in those countries alone. And that's a big deal because it dwarfs what we've been estimating and what we talk about in terms of the amount of AF that we have to deal with. And we put this into the American guidelines as to the consequences of AF. And this is a big deal as well because we've gone from a disease that was a bit of a nuisance to a disease that actually has big implications, more than just stroke. We're talking also about a all-cause mortality. We're talking about heart failure. We're talking about cognitive decline and dementia. These are significant to the community, and so we need to kind of change our approach on what we're going to do for atrial fibrillation. I'm going to show you this data from our group in Australia, looking at AF as a primary diagnosis admissions to hospital. And that's shown here in blue. And what you see is that over this 20-year period, it's gone from this disease that we all thought will give them a bit of digoxin to one that is now more common a cause of being in hospital than either heart failure or myocardial infarction. So this is costing our health system significant amount of dollars. And so we really do have to take a different approach to how we're managing this condition. Otherwise, we're going to continue to face these sort of costs in our community. And one of the cool things about our area is people have been really interested in working from mechanism through to translating that into how we can help patients. And some of the early data on the mechanisms have really come from Canada. And I want to give a shout out to Carlos on this one. I don't think in history he's had enough credit given to him for this work. So this is work where they paced the atria at rapid rates in canines and looked at what happened to the remodeling. And he was able to show that the atria increased in size, there were ultrastructural changes, and the posterior wall was very fast in its activity. And when they ablated in that area, it terminated atrial fibrillation. This is a big deal and way ahead of anything that pointed to the pulmonary veins at that point of time. So this was really a novel thing. It was dwarfed really by the fact that in the same year, Moritz Alessi's group did a similar study in goats, and they coined the word AF begets AF. And that took over as what was the first study, but it wasn't actually the first study. What that study did was it drew attention to the fact that the atrial refractoriness reduced as a result of AF, and that was proposed as the mechanism by which AF would propagate itself. And in fact, for a long time, people were saying that's why we get AF. It's because your refractoriness goes down. And that was a bit of a misunderstanding there. And then it was really another Canadian study that really shed new light on this. This is from Stan Nattel's group. And he kind of took the approach, well, you got to have something to get the AF going. It can't be that AF is going to propagate itself on its own. And so he looked at a heart failure model, rapid ventricular pacing heart failure model. And what he showed was that in the atria, you had scar tissue forming. And this scar tissue resulted in conduction heterogeneity changing within the atria. And so we suddenly changed our focus completely from focusing on refractoriness, which in fact goes up in this model, to one of focusing on the underlying substrate in terms of maintaining atrial fibrillation. And so these are two really important studies in our field. And this is the point at which we entered into this area, and we kind of brought this into the clinic to try and understand, is the same occur in our patients with predisposed to atrial fibrillation? This is one of my early studies. It looks at patients coming in for defibrillator implants, and we took the opportunity to map their right atrium. They didn't have a history of atrial fibrillation. This is what the first CARDO system that we had in Australia. It was a point-by-point map. And for those of you who don't deal with these maps, what it's showing is the voltage of the atria. Red represents low voltage areas, gray is scar, and purple is healthy muscle in each of these maps I'm going to show. And the points that are marked are abnormal conduction points within the atria. And you can see, compared to the patient who's an SVT patient on the right-hand side, this atria is quite sick. There's low voltage areas and there's abnormal conduction. And it's no surprise that this atria will sustain atrial fibrillation. It corroborated the data from Stan Nattel's group that scarring and structural change was an important factor in the atrial substrate. We've now gone on to look at a number of different pathologies that are known to cause atrial fibrillation. I want to show you this because I'm going to come back to how this highlighted some of where we needed to go. This is work on mitral stenosis, and we were able to map both the left and right atrium because these patients were undergoing balloon commissurotomies at the time, and so we had access to the left atrium as well. And so you can see the electroanatomic maps, the mitral stenosis atria, red, showing low voltage, the abnormal points compared to the patient who has a WPW, in this case, left-sided pathway that we've used as a control. We also got adventurous with the amount of catheters we were able to put in to determine the conventional electrophysiological parameters as a result of this. And we learned a lot about what we could get in the clinical setting. But we still didn't know how the progression occurred. And I want to highlight this work from Dennis Lau when he was doing his PhD. So we went back to our ovine model, our animal facility, and Dennis did this incredible thing where he removed a kidney and he put a clamp on the second renal artery to cause renovascular hypertension. Then he took it a step further and he opened the pericardium and put a high density plaque on the animal's atria, tunneled it up to the neck so that we could now plug the animal in and do ambulatory EP as the animal became hypertensive. And so what we see here in the top row is activation going from red through to purple. And over a 15-week period, it takes longer time to get over that. And you see the crowding of the isochrones, that is the conduction heterogeneity occurring. In the middle row, we see picroserous red staining, which is showing scar tissue in the interstitium. And it's progressive over the whole 15 weeks that this animal has hypertension. And we also see inflammatory cells going into the myocardium. So there is although it's a systemic disease, we're seeing a localized insult at the atria, changing cardiac structure. And in fact, Dennis was able to identify that the entire fibrotic cascade is activated with angiotensin 2 levels, TGF-beta levels, endothelin-1 levels, and also CTGF. These are all the standard cascade that leads to fibrous tissue being formed, and all of them are activated in this model of hypertension. Is it the same between different insults? And we've looked at that in obesity. And so we have had a chronic obesity model where we've basically treated sheep like humans. You put food in front of them, they eat it. And they get overweight and obese. And we can actually, it's interesting because this model didn't have hypertension, it didn't have metabolic syndrome, but their atria was getting damaged. So on the left-hand side, we see the fibrous tissue in red. So there was scar tissue forming. And then we saw something novel. They had pericardial fat increases, and this fat starts to infiltrate into the myocardium. So they can form islands of inert tissue within the myocardium, which can then give rise to AF as well. There's a bunch of changes that occur, but this suggests that at least at the cellular level, there may be some differences between what happens due to the different insults that people have. We've highlighted this. So, in hypertension, you may have more areas of scar tissue forming between the cells, whereas in obesity, it may be more the fat cells that have a bigger contribution. But what we saw clinically is it didn't really matter what happened at a cellular level. The clinical phenotype that resulted was the same. And here's a slide we put together with Stan Natel. This row in the middle shows the different disease states that we had evaluated, whether it's aging, whether it's hypertension, heart failure, sleep apnea, or obesity. We have the same thing. The left atrium is slightly enlarged. They have loss of myocardial cells, and so there's low voltage areas. Sometimes we had scar tissue, but there was a gross change in conduction, and there were abnormal conduction points. And this seems to be the clinical phenotype for the substrate for atrial fibrillation. Now, I want to touch on the lone atrial fibrillation. This is a paper put together by Dr. Wise and a number of luminaries around the globe. And they questioned about the existence of the entity lone atrial fibrillation. There was a really nice white paper in JACC, which really said, we went from 30% and we think, actually, it's much lower. I'm going to extend this and say, actually, it doesn't exist. If we have someone with what we think is lone AF, we haven't identified what that risk factor is. And hopefully during this talk, I can show you some of the new data related to that. Here's our paper on lone atrial fibrillation. So we took patients coming for AF ablation, this took a number of years to collect, who had no risk factors for atrial fibrillation. And when we look at their atria, this is down the bottom, compared to the patient with WPW, again, it reads low voltage, this atria is already damaged. So although they have no identifiable condition, the atria actually has the same phenotype as what we see in all the other conditions. So there is something going on here that is affecting the atria, giving rise to atrial fibrillation. Now, Stan Natel wrote this beautiful editorial that I want to highlight, because what he did is he said that cardiac disease, mainly talking about heart failure, valvular disease, and coronary artery disease, alters the atrial myocardium. It causes structural change, it causes electrical change, there's autonomic changes, and there's also calcium handling changes, which give rise to atrial fibrillation. And then highlights the fact that when you get atrial fibrillation, all of these factors are affected again to kind of self-propagate itself. But what we are aware now is that aging does the same thing, okay? We're aware that hypertension, diabetes, and alcohol excess also does the same thing. And suddenly we've got a whole plethora of new players on the block in terms of risk factors that are starting to accumulate in our community that are all associated with some of these changes. I'm going to show you some of the data associated with this. This is work from Adrian Elliott, and he's looking at physical activity and the occurrence of atrial fibrillation. And the reason I'm showing this is obesity is almost at a point where it's going to take over from hypertension as being the highest attributable risk. Physical activity is increasingly a problem in our communities, and this is a close second to the obesity in terms of risk factors that we need to be attending on. So this figure on the left is a summary. The size of the round circles is basically the populations, but as your cardiorespiratory fitness goes down, your incidence of AF goes up. And then on the right is data from the UK Biobank, which is kind of interesting because initially in men, it's protective, but then as you keep exercising, then it gets more harmful. And this is seen in the kind of athlete's heart. Now, this is where it's interesting is women, all exercise is good. And that's also borne out with the data from athletes, where none of those studies report that women have a higher risk of atrial fibrillation. It's one of those differences that we are still trying to tease out in terms of why this occurs. Alcohol is an important one in our communities, and each community is a little bit different. This is from Chris Wong and Samuel Tu, using the UK Biobank data. Early on, there's a protective effect, but then it's an escalation up. There may be differences between the types of alcohol, not all are equal, but it's something that we need to be aware of as we try to counsel our patients on this. So I want to change tack now, because one of the things that our community in EP are moving towards is early intervention to restore sinus rhythm and maintain sinus rhythm. And this has had a lot of a push in recent times, a lot to do with the EAST-AF-NET study from Paulus Kirchhoff. This study looked at treating AF within the first 12 months of its occurrence. You'll notice that this is the ablation group. It's tiny, and at the end of the 2 years, it's only 20%. The rest of it was done with antiarrhythmic drugs. But what the important thing is, it reduced death from cardiovascular causes and stroke, at least in this series. And we also have ablation data now, both from Jason Andrade, and also this is what I'm showing you from the Cabana trial. When they actually used a per protocol analysis, there was significance in terms of these hard endpoints to actually do these things early. And so there's an intense focus on ablating earlier for maintaining sinus rhythm. Now, I want to put this into context, because here's a study that we published some years ago. There's a patient with atrial fibrillation on the right-hand side here. This is both right atrial maps compared to an SVT ablation patient. The patient with AF has got some low voltage areas. There's greater areas of red that's seen on this atria. Now, this person has a pulmonary vein isolation procedure, a left atrial procedure. They have no AF for 6 to 12 months, and we bring them back to the lab. And what do we see? We see that the atrial disease progresses. There's more red here. Their activation time is still prolonged, and there's more areas of fractionation. So although we've got rid of AF, the disease progress is continuing to progress here. And so if we rely on just the AF ablation here, we're going to see AF come back again. And so it's really important that we put this into context in terms of what we should be offering our patients. Now, I want to bring you back to the mitral stenosis patient. And in retrospect, it's kind of obvious, but at the time it wasn't so obvious. So here's the right atrial maps pre-procedure. And this is immediately after doing the balloon commissurotomy. So we've reduced the pressure within the left atrium, but I'm showing you the right atrial maps. Not much of a change. There's still areas of red. There's still abnormal conduction with these points. But we brought these people back 6 months later and reassessed the atria. And the atria improved. Their voltages went up, their fractionation went down, and at the time, it was really hard to describe why this occurred. And I was talking about atrial size reducing and maybe better contact with the catheter, and I was making excuses for this. Now, in retrospect, this is actually reversal of this substrate for AF by treating the primary cause. And I'm going to show you more data associated with this. And around the same time, Christine Albert's group published this interesting paper from the Women's Health Study. And so what they'd been following women for a long period of time, and what they described was women with a BMI less than 30 had a lower risk of AF than women who had a BMI over 30. But then they described the transition. If someone with a low BMI went to a high BMI, they took on a higher risk of getting AF, and vice versa. If you had a high BMI and you came down, this is in a population study. And so I think this also gives us an idea that this process is a little bit dynamic. And so we've focused on this a lot, and we now know obesity has significant implications to AF patients. There are a number of mechanisms by which obesity leads to AF. But the thing I want to highlight in this is that often these conditions coexist together with other conditions that promote atrial fibrillation as well. And so it's very rare for us to have a patient who has only one risk factor for atrial fibrillation. There are now, we've well identified several risk factors that are modifiable that actually contribute to atrial fibrillation. Now, each of these that are listed here have been associated with altering the atrial myocardium, either in preclinical or in clinical studies to promote atrial fibrillation. And so we now have a bunch of things that we can actually target. And so that's what the approach that my group has been taking. And we've taken a comprehensive approach. So that is, we look for each risk factor and we treat each risk factor that is important for that patient. Okay, so it's not a choice thing, it's each risk factor. We've targeted overweight people, and so we aim for a BMI less than 27 and a 10% weight loss. We increase exercise. Blood pressure remains crucial. I don't think we treat it very well. So we actually aim for a blood pressure less than 130 on 80% of the time, and we get the patient to monitor these. But we also look for exercise-induced hypertension. I think that's under-recognized, and look for left ventricular hypertrophy on echo, because I think that's unrecognized as well, that there's underlying hypertension. Diabetes, most of it we manage. We occasionally need to send them off to the endocrinologist, and our plethora of medications here has expanded dramatically. Sleep apnea, if we're going to try and maintain sinus rhythm, we look for sleep apnea and treat. I think that's something that we could have a discussion on. Lipids are to guideline levels. We aim to stop smoking. And although we have this great paper from Pete Kissler about abstaining from alcohol having a dramatic effect. In fact, the other thing his paper showed was none of the patients were willing to do it for more than 6 months. 3 standard drinks for a week was an achievable target, and we seem to achieve that in the majority of our patients. And so that's actually what we've written in the guidelines as a result. Let me show you the data associated with this. This was our first study, which is now well over a decade ago. And it was a randomized study taking people off our AF ablation waiting list to undertake this. Quite an intensive program. You can see almost a 5 to 6 point reduction in BMI over a 15-month period in these patients. And then they had a dramatic drop in their symptom score, AF symptom scores. And when you did ambulatory monitoring, they had fewer episodes of AF and they lasted for a shorter period of time. I'd say 40% of these patients came off our AF ablation waiting list, which is dramatic. Now, the question is maintenance afterwards. So there's still more work to be done here. And then we've reported a bunch of observational studies from our series, now including large numbers. Arrest AF, this was an observational series in patients undergoing AF ablation, looking at the obese cohort with at least one risk factor, so a group that does bad to start with, and looking at the impact of treating risk factors. And you can see whether it's single procedure or multiple procedure success, it is better if we're able to manage their risk factors at the same time. And so this is an encouragement that we can actually make a difference. And then in Legacy, we extended this to not just patients who are having AF ablation, and we tried to give a bit of a grading on how much that needed to be done. Is there a benefit in a lower degree of weight loss and risk factor management? And there is. It's staged. The more you're able to achieve, the more likely you're going to be able to maintain sinus rhythm. But I'll also highlight, this is 1 out to 5 years, and 2 is that 46% are in sinus rhythm without the use of antiarrhythmic drugs or ablation when they've lost 10% of weight and managed their risk factors. So now this is observational data, so it's really important to look at it in that context, but it really does say that this may be the way that we need to address the growing number of patients with atrial fibrillation. I'll also highlight Melissa Middledorf's study because this actually tells us we can change disease course. So in the middle here, we have what we expect. Over a 5-year period, if you don't manage your risk factors in green, you go from paroxysmal to persistent in 48% of cases. But then on the right-hand side, if you manage your risk factors with over 10% of weight loss and managing your risk factors, 88% of persistent AF goes to paroxysmal or no atrial fibrillation. This is big because we're all looking for how we should alter the substrate when we're doing ablation. Maybe the answer is not in ablation, and that we need to start looking elsewhere as well in terms of how we address this factor. We've also put out recently more randomized data, and I'll just show you a couple of this active AF. And I think this is the one risk factor where you can actually target as the single risk factor because it affects blood pressure, it affects metabolic state, it affects weight as well when you treat exercise. This was an intensive program where an exercise physiologist worked 3 times a week with the patient in clinic and then gave them a homework schedule of exercise and clearly shows reduced recurrence of atrial fibrillation and also an improvement in symptom burden. And this actually is what informed our guideline recommendations. And then at AHA, we presented our prospective study of the AF ablation group. This is a multi-center randomized study looking at intensive risk factor management in patients undergoing AF ablation with loop recorders in, looking at recurrence of AF, and confirms the data that we've seen in our observational study that this needs to, this is under review, so hopefully we'll see this coming out soon. I'm going to highlight the fact about we have evidence about whether we can treat single risk factors, and I want to give this a bit of a warning. This is Ratika's paper in hypertension associated with AF ablation. So she multi-center study, mainly done in Canada, and randomized to aggressive treatment of blood pressure versus standard treatment, and found no difference in the outcome. And I think the biggest issue here is it's one risk factor in isolation, and it is a modest risk factor in these patients. When you look at the baseline blood pressures that they recorded, I think you can treat a single risk factor if it's a dominant risk factor. So we have got hypertension studies where they've had to do renal denervation, which are positive, okay, where they're on 5 agents before they get in there. But I think in the most of the patients that we're treating a single risk factor in isolation may not be so useful. We've also got data in alcohol, Pete Kissler's study, where you get them to abstain when they're drinking a crazy amount, and you can see a significant difference. But outside of that extreme, I think we should be treating this as a multifactorial disease to be able to manage AF. Also want to highlight that there's a lot of interest in doing multi-center studies with interventions to manage risk factors. And I'm going to show you this as an example of why we need to be cautious in interpreting the literature. This is from the group in Europe, multi-center study. They used dietitians to try and counsel people to reduce their weight. And they did claim that they significantly reduced weight, but the BMI went from 34.9 to 33.4 over this period of time, which is less than 3% and was our control group. And not surprisingly, they had no difference in terms of the AF outcomes. Now, one of the hassles is if you don't have an intervention that's proven to work, there's actually no point doing the multi-center study. And so it may be that we've got to create the intervention and make sure it's reproducible at different sites in order to sustain a difference. So we're still without a multi-center randomized study that's been done appropriately for this data. Now, we know our clinic works, and the AFNet era consensus got us to put the what we do together, and they've labeled it in the publication as the Adelaide model. I don't think it's anything special, and it is one model. It doesn't mean that there aren't other models that will work. A couple of the highlights that I would say from our clinic is we separate out the arrhythmia clinic from the risk factor clinic because it's information overload for the patient if they're trying to take everything in. But the arrhythmia clinic has a pivotal role in actually encouraging the patient about the importance of risk factor management because the patient's coming to the arrhythmia clinic. That's their main symptom. So that's a really important focus. And then we broke it down into a 4-step thing. And the first step, in my opinion, is probably the most important. It's actually getting to know your patient, getting to know their health literacy, getting to know their family situation, getting to know their barriers for each intervention. And really, that's actually done really well by our nurses, perhaps done less well by us who have a very short consulting time to be able to do it. And then there's a concept that's come out of Harvard called structured educational visiting. It's a really important concept. It works, and we know it works because that's what pharmaceutical industry does to us to get us to prescribe. But following that sequence actually allows you to make change. It encourages a patient to come up with some options for treatment. And when you ask them to set goals, patients always set goals that they can never achieve. So it's our job to bring it down to achievable goals and reassess this over a period of time to then get to the eventual targets that we're trying to achieve. And I want to go through some of that, but it's in the literature, but it's one model, and we're certainly open that there could be other models in different healthcare systems. We're at the moment trying to put this into a digital framework where there's a digital helper for the trainer. And we're running this study in 5 centers in Australia now. So it's built on REDCaps so that it's very transferable to academic centers. And hopefully, once we do the pilot, we're going to try this out in a wider group of people. Our job may have got easier as a result of the weight loss drugs that are now available. Okay, this is something that we need to be open to as a possibility. This is from the Hopkins group. They took out of a research database network, they took patients who've undergone AF ablation, who were also on GLP-1 receptor agonists. They propensity matched this quite large group, 1,600 in each group, and they looked at AF recurrence and they looked at hard endpoints, and unfortunately they found no difference in this group. There's a couple of limitations here. It's a retrospective data, and we really don't know how long people were on GLP-1 receptor agonists. Now, we have about just over 200 people on these agents, and we get tremendous weight loss. We don't see as much of a benefit in the AF side of things yet, and maybe early days. And I think part of the reason is the patient focuses less on the other lifestyle issues that they need to be undertaking at the same time. The exercise, the alcohol side, the giving up the smoking, they still, weight's their main focus. And so it may be a distractor. We need more data. We're teased by Jeff Goldberger's data, which really is a small series, but in a post-AF ablation group, liraglutide had a better outcome than in terms of AF recurrence. I note that there's a couple of RCTs being presented at FHRS this week, so we may have more information to help guide us in this regard. Now, how do we reverse this substrate? And I want to show this to you because we've gone from thinking about it as Stanley tells studies, which was this is now scar and we can't reverse it, to actually starting to recognize the concept of reactive fibrosis rather than replacement fibrosis. So this is in our chronic obesity model, and we now diet restricted the animals to get them to lose weight, and we evaluated them at 15% and 30% weight loss. This is the activation maps on the top, control, and in the obese state, you can see it goes from red to purple, takes a lot longer. And there are all these isochronal crowding, which is conduction abnormalities coming in. By 30% weight loss, that's completely gone away. Now, fibrosis here is with Masson's trichome, blue staining, massive increase in interstitial fibrosis, and it goes away by 30% weight loss. And so here comes the concept that this is a reactive process, and it's not like myocardial infarction where you've actually replaced tissue. And so that's a possibility. Now, the one thing we didn't see completely go away was fat infiltration. You get fat infiltration, there's still fat infiltration, but it's perhaps a function of how long we waited, and perhaps if we wait longer, that may go away. Almost everything else reverses in the obese model. Does this happen in the clinic? And I'm just going to show you this. This was presented as a late breaker at FHRS and is still in the review process. So we took patients, we randomized them to standard of care or to aggressive risk factor management. And we have studied their atria at baseline before we randomized. These are both right atrial maps in a control patient and in a risk factor management patient, red being low voltage, the abnormal points are conduction abnormalities. 12 months of risk factor management, and we restudied these patients. This is the atria in the control patient, maybe slightly progressed. This is the atria in the risk factor management patient. This atria recovers. The conduction abnormalities go away. And so in the clinical situation, we can see a benefit in the patients. In terms of their structural change, their left atrial volume reduces more dramatically. There's a reduction in septal dimension. There's improvement in diastolic function. In cardiac MRI, there's improvement in LV mass, a reduction in pericardial fat that's significant. And in terms of circulating fibrotic markers, there's a significant improvement as a result of managing the risk factors. But here's the teaser. If we start looking at things that promote thrombosis, there's an improvement in endothelial function, there's an improvement in all markers of platelet function, and there's an improvement in all the biomarkers. And so this is a teaser because we need wider data on this to see can this actually alter what we're doing? And so this sort of data actually forces us to start thinking, well, this should be the first pillar of AF management. Actually, we introduced that with Mina Chung's help in an AHA document where we put lifestyle and risk factor management as now the first pillar of AF management as an essential component. We've been trying to make this a little bit easier, and so we're keen on all clinicians taking part in this process. And so one of the things we introduced into the literature is the concept of looking at the patient from head to toes in terms of the risk factor, an acronym that you can use at the bedside and everyone can use at the bedside. This is driven by Melissa Middeldorp, and she was working with both Christine Albert and Isabel Van Gelder. And so we've put this together as a global review in order to encourage people to use this concept. Now I'm going to put the H for heart failure. I put it in at the last minute, and I put it in the last minute because of some evolving data that we have. We put it there as the treatment of HFrEF, but I want to show you this data, which is from Jonathan Ariaratnam. So we've been looking at the hemodynamics of the atria as we undertake our AF ablation procedure. We've put a pigtail in the right atrium, we measure in the left atrium, and we kind of look at HFpEF physiology in terms of a pressure over 15, we then give a fluid infusion into the left atrium and look at how the atria performs, both looking at a transesophageal echo image to see how it dilates, but also on what the pressure does. And there's a group of patients who fit into what we call early HFpEF, where the pressures go up and don't come down so easily. And then there's a group that's completely normal. But the scary thing is, these are patients who have no clinical HFpEF. And 47% of them have HFpEF physiology, and another 26% of them are well on their way to HFpEF physiology. I think this is the under-recognized risk factor that we now need to start looking for, and perhaps we should be starting to treat. And we've got RCTs going now to start looking at whether, especially SGLT2 inhibitors, whether there's a potential role for them to be improving ablation outcomes. In this population, as you get from no HFpEF to HFpEF, there's worse LA compliance, there's less reservoir strain, and there's greater remodeling of the atria. These are sicker atria as you get more HFpEF, and perhaps we should start thinking more from an ablation point of view, whether there is other things that we need to be treating in this regard. So we're changing our understanding. We've gone from thinking of AF as paroxysmal to persistent to permanent as the substrate for AF increases in the atrial tissue, to now really thinking that we can target these risk factors, change the substrate, and actually keep this paroxysmal or no atrial fibrillation. There is a different approach to managing this. What's also become apparent is we've now got a lot of upstream targets that we may have new drug developments occurring to be able to target upstream. There's going to be a whole new realm of therapy for atrial fibrillation that's already in trials currently. So let me close with showing two slides from the guidelines to put this into perspective. The first is that we've made AF, the modifiable risk factors as the central pillar here. We did put in the steps that we need to enact behavioral change. And in the steps, I also introduced the head to toes concept so that it's now in the guidelines for people to use at the bedside in order to target that. We took a different approach with the European guidelines. We highlighted the fact that we've introduced AF care as the model of care. We see the comorbidity and risk factor management was the first pillar that we used here. It's really to emphasize that this is actually all physicians dealing with patients with AF. And I want to highlight the last one that we introduced, which is the E, which is the evaluate and dynamic reassessment. I think we as clinicians forget our patients are getting older and they're getting more risk factors each year, and we don't reassess their stroke risk or their risk factor risk at that point. And so that reevaluation needed to be emphasized. So let me stop there and take any questions. I'll recognize my current group and facilities, and thanks for having me here.
Thank you so much for that excellent talk, Dr. Saunders. We will open up the chat for people online. If they would like to type in any questions, that would be great, or you can speak up. And I'll also open the room to questions. Look at that. Satish, why don't you start?
Of your talk, you talked about sort of the model that you had where you had the arrhythmia clinic and basically the risk factor modification clinic. Who runs that? Is that you from a distance and the nurses are running it, or do you have internists or family physicians? Who's doing that?
So I actually can be anyone. Okay, we have had a range from electrophysiologists running it, general physicians run it, nurses running it, pharmacists running it. We've even had a medical student running it effectively. Okay, so this is actually not that hard to do. It's just learning the process of how to do it to deliver a change. And it's more becoming the patient's buddy on where we can make changes. And we just, unfortunately, in our clinics, we just don't have the time to be able to address this. This is where people who have the time, and nurses follow that really well when you give it to them. So we've had Jeroen Henriks, who did the AF nurse clinic data from Maastricht. He spent 6 years with us and has kind of evolved a bunch of people who are doing this in the clinic now.
Prash, great talk. Thanks for reminding me of that paper. It was 30 years ago. So kind of dates. A couple of questions there. One of the things that you always talk about with risk factor modification is the residual risk. So what is the residual risk that we have after modifying all these factors? And second, what is the proportion of reverse remodeling that we're going to get before age offsets all of that?
Yeah, great question. So I think age and genetics, two things that we're not at this point able to change. But I think we can defer the AF burden down the road, and usually to an age when they've got so many other things going on that this is not a big issue for them at that point of time. Okay, so we're going to change that equation. Some really interesting data from Sean Evans from my group, who has been looking at biological age versus chronological age. And you can actually change someone's biological age by managing their risk factors. So I think we're going to be seeing a dramatic change in that as well. So we need more data, but you're right, it will catch up with us at some point.
Yeah, thanks very much for the lecture. So I wanted to hear more of your thoughts on the exercise part of it. So, I mean, we know that extreme exercise can increase risk for AF. Probably most people are going to benefit, but I'm just curious what your experience is, and is it the kind of exercise that matters, resistance training? Talk about those kinds of things.
Yeah, so look at most of the data in terms of AF is actually aerobic exercise, which is going to be beneficial. The resistance is great for weight loss, but in terms of benefit for AF, it's less so. I think most of the patients we're seeing, they're never going to become endurance athletes. So I think we're pretty safe. I tell them under an hour a day is fine. Okay, once you start going over that, and really the endurance is maintaining your heart rate at a high level for prolonged periods of time. So that risk goes up after about 4 hours of training on a regular basis. In between the 1 and 4, it really depends on genetics as to whether you're going to be prone to that. So it's a little bit, I mean, I guess we're still working on the mechanisms. Mechanisms are that you're vaguely stimulated, you're bradycardic at rest, you've still got to take in the same amount of blood volume, and so you stretch all your chambers up, and you are going to get scar tissue from that. We're studying, interestingly, some trotters, horses in Denmark, because it's a great model for athletes, and we're seeing similar sort of changes in those horses. So I think we're going to see scar tissue forming in those athletes. But I think for the 99% of patients we're seeing, it's safe to recommend exercise.
Catherine.
Okay, great talk. Lots of questions. First of all, have you given a GLP-1 to your sheep to see if the fat tissue resolves?
I have not. Look, the fat tissue, we are seeing, and we've actually published a little bit of work on this, the pericardial fat reduces, but the fat in the myocardium, I think, is going to take a little bit longer to go away. I don't think that's so easy. It also overlaps, interestingly, with the sudden cardiac death group, because obesity is associated with a group of patients who die suddenly, and we are seeing fat infiltration of the ventricular myocardium in that group as well. And so it may have implications. I hadn't thought of giving GLP-1s to sheep. I'm not sure how effective it is in sheep, but it's a good thought.
The other thing is, I mean, we're overrun with atrial fibrillations, and the waiting lists are very long, and you're promoting doing it early. By the time we put them on the list, and they get there, it's already late. Are we ablating the wrong group? Is there a point of really no benefit for ablation in the later group?
Yeah, I think there's a group of patients where there is no benefit. I think once your atrial size is above 150 mils, you got to kind of think what your chances of maintaining sinus rhythm. Now, having said that, I have a couple of people who you aggressively treat heart failure, you aggressively treat risk factors, and the atrial size drops to a level that you can actually safely do an AF ablation procedure. So I don't think you should write them off, but they've got some other work to do before we can take them in. Look, the reason all of our programs started is because of our AF ablation waiting list. So, when I came back from Bordeaux, suddenly there was 2 years of patients, and I had to entertain these patients somehow. So I'd send them off to various clinics, hypertension clinic, obesity clinic. And by the time their AF ablation came up, some of them didn't have AF anymore. And that's how we put this story together. Okay, so I think there is a role of using that time on your waiting list to start treatment. And one of the reasons we've moved this to the first thing for an AF patient.
But if you've already got fibrosis, and it would be important to try to distinguish your permanent fibrosis versus substrate, a resurgent fibrosis, I think you call it, a reactive fibrosis.
Yeah, so the only
way of doing that in the live
not so easy. So let me tell you, the only group that has said there's a point of no return is Andre Natali's group, and it was a specific group of patients, morbid obesity, BMI over 40, with long-standing persistent AF. Okay, so they've had continuous AF for more than 12 months. Now, those patients, they felt weight loss had no impact at all, but they did end up ablating them all, okay? Now, if you look at the Cleveland Clinic has put out data in morbid obesity using bariatric surgery, and they are showing the same results we have, okay? So there may be a group, it's yet to be identified. If the MRI technology to assess scarring was reproducible, that'll be a pretty cool thing to kind of be able to say, we have reversible fibrosis and we have reactive fibrosis, but I don't think the technology is there enough for us to go to all labs and be able to reproduce that.
But there's a difference between structural and electrical fibrosis. See, one thing is what we show on these voltage maps, which probably doesn't have anything to do with the structural fibrosis. And that's where, that's why, some of the trials have been, the Sears trials have been negative, the decaf trials. So I think we still have a little bit of a disconnection in our understanding of the mechanisms of what we see that we call reduced voltage. It's not necessarily fibrosis. It's more of a structural conduction. It's a combination of factors. So we still need to understand that better, because sometimes you see patients that if you do one of these fancy MRIs, there's a lot of scarring, and then you do a voltage map and it's pretty good. So we still have a disconnect there.
Can I just add something to that?
Yeah.
In paroxysmal AF patients, voltage maps are virtually, 80–90% of them are normal. And in the persistent population, it's still hard to find low voltage areas. We've been enrolling patients in COAST AF, which, as you know, is a strategy of PVI versus PVI plus ablation of low voltage areas. And one of the problems with that trial is that despite finding a population that should have a high incidence of low voltage areas in the left atrium, we're finding that a lot of patients don't have low voltage areas, even though they have persistent AFib. So most of the voltage maps in the patients that I ablate are purple.
So you got to look at the range that you're using. So the data I presented is comparing it to SVT patients, and you see a difference. Okay, and we use a range of 0.5 to 5 to show the difference. Okay, if you bring that down, as most people do, using kind of soft data from Frank Marchlinsky from the ventricle down to 1.5, everything's purple. Okay, so it depends on the range that you set, as to whether you're going to identify subtleties. Now, in terms of ablation and a trial protocol, they've set this is the range we want to be doing it in, but it doesn't mean that they don't have low voltage areas when you compare it to a structurally normal heart. Play with the voltage.
If the limit of normal for ventricular myocardium is 1.5 based on a population study of normal people, it's a little bit hard to understand.
No, you're looking
why-
at the wrong way. That's the limit of SCAR.
Scar.
It's looking at the lower end. It's not looking at the higher end. And so if you want to see the spectrum of voltages in the atria, you want to actually increase your bandwidth as opposed to narrowing it down. Okay, so you will have the same changes. It's just that for the study you've narrowed down your bandwidth.
Rupi, what did you have?
I just had a quick question about all of the randomized clinical trials you've done with lifestyle modification. If you captured any neurological assessments or cognitive assessments?
What's going on? Look, it's a tough one because the changes are quite subtle. So we have been, we published a paper with John Kalman, which was actually scary because 40% of AF ablation patients have contemplated suicide. Okay, so there is not just cognitive issues, but there's actually psychological issues there as well. And John's nicely done the study of showing that after ablation, cognitive function improves. We're just working on the mechanisms, the lymphatics of the brain. There's some really interesting data that we published at European Heart, how that's changing with restoration of sinus rhythm. So there's more to come in this.
Bob, can we give you?
Okay, I'm sorry, I'll catch up with them later.
Okay. Get the last question.
Great, it's a bit of a philosophical question. You're involved in a lot of guidelines on AF, both the ACC guidelines and the European Society of Cardiology guidelines. Yet, on these guidelines published almost simultaneously, there's two different frameworks that may reflect the same thing, but I'm just wondering if you could speak to that. I mean, one of the criticisms of guidelines is, and this is both cardiology guidelines, but every specialty has their own thing, and in theory, the guidelines are supposed to be universal for non-specialty physicians. Are the Europeans, asking the Europeans and the Americans to treat this differently?
Yeah, so it was fascinating because I was the only one on both writing committees and they were going concurrently and you couldn't share data from either, which is kind of interesting. So the American guidelines are very rigid. And so you were either black or you were white. You didn't have shades of gray. Okay, so you didn't take into consideration expert opinion or this is actually good for the patient or anything. There was hard RCT data or there was not. Okay, so that's how the American guidelines were built. And then you could put stuff in the text, but you couldn't make it a guideline recommendation. The European guidelines is much more about the physician at the bedside and how to enable them to make change. Okay, and so it allowed a little bit more room to move in that. And I think traditionally those guidelines have taken that approach. My sections were exactly the same in both. Okay, there was, maybe the wordings were slightly different. I mean, we emphasized more. So a classic example with the risk factor side. So in the US guidelines, it says exercise to 210 minutes to reduce this. In the European guidelines, it says exercise in the context of comprehensive risk factor management. Okay, it allowed that to go in because that's what the data said, whereas here, it just wanted a black and white response, and you didn't have room to move on that. Lots of arguments. Oh, wow. I mean, those calls were like insane, huh?
So thank you very much.
Thank
We're at the
you.
top of the hour, so I think we'll shut it down. Thanks.